Good morning, everyone. Hi. I'm so pleased to introduce our speaker for this morning's annual Silber Lecture. The Silber Lecture is sponsored by donations made by Dr. Silber's patients for the purpose of disseminating information on clinical and research updates in the field of eating disorders by the national and international leaders in the field. Dr. Silber did his pediatric residency at Thomas Jefferson Hospital in Philadelphia and his fellowship in adolescent medicine here at Children's National in 1969. He joined the Division of Adolescent Medicine in 1973 and is a GW tenured professor of pediatrics. He has edited several textbooks and published more than 200 articles. He is the medical director of the Donald Delaney Eating Disorders Program, and we are so very proud of the multidisciplinary team that has provided these services at Children's National for several decades. We are equally thrilled that Dr. Silber has invited Dr. Neville Golden to deliver the Silber Lecture this morning. Dr. Neville Golden is the Chief of Adolescent Medicine and the Marin and Mary Elizabeth Kendrick Professor in Pediatrics at Stanford University School of Medicine. He's been treating adolescents with eating disorders for over 30 years and has studied the medical complications of eating disorders in children and adolescents, focusing on the etiology and implications of amenorrhea and anorexia nervosa and nutritional rehabilitation or refeeding in this population. He is the co-principal investigator of an NIH-funded randomized control trial comparing the effect of higher versus lower calorie refeeding on clinical remission, on safety and cost effectiveness in anorexia nervosa. He's a past member of the American Academy of Pediatrics National Committee on Nutrition and is the lead author of the AAP's clinical report on preventing obesity and eating disorders in adolescents. And he's also the lead author of the Society for Adolescent Health and Medicine's position paper on the medical management of restrictive eating disorders in adolescents and young adults. He's a member of the editorial board of the International Journal of Eating Disorders and the author of over 200 articles, abstracts, and chapters. It is with great pleasure that I introduce you to the 2018 Silber Lecturer, Dr. Neville Golden.
Thank you very much. What a wonderful honor it is to have a lecture in your name. And that's a true testament to the high esteem in which you're held, Dr. Silber, by your colleagues and, more importantly, by your patients. Thank you, Dr. Tuchman, and thank you, Dr. D'Angelo, and Dr. Silber as well for inviting me here today. Yeah, we have a picture of our esteemed person about whom this lecture is named. So what I propose to do today is to, by the end of the day, hopefully you'll be able to understand a little bit about the changing epidemiology of eating disorders in children and adolescents. Hopefully you'll be able to identify 3 indications for hospitalization of a teenager with an eating disorder and cite 2 factors associated with refeeding syndrome in anorexia nervosa. And if there's time, I'll read you a poem at the end written by one of our patients and leave some time for questions. I'm going to focus on the role of the pediatrician, and in particular, what I'd like to do is challenge some of the old concepts regarding medical management, in particular refeeding, and also bed rest, which when I came into the field, people were being refed really, really slowly and kept on bed rest for days and sometimes even weeks. And much of the research is actually being conducted here by Dr. Silber and his colleagues. So hardly a month goes by where there isn't some mention of eating disorders in the lay press. This is an article from the New Yorker last year about the Netflix movie To the Bone. And what was interesting here is both the producer, writer, and the actress suffered from anorexia nervosa. And what was controversial is the actress actually lost 20 to 25 pounds in order to play the role. What is clear is that this is the image that young people are given about what is success. This is not from a teen magazine. This is from the New York Times, that thinness is equated with beauty and success. And it's not surprising then that large numbers of young people are trying to lose weight. These are the most recent data from the Youth Risk Behavior Survey, and you can see here that approximately 2/3 of young women and 1/3 of young men have tried to lose weight in a prior year. And it's about the same across different ages. And you can see that this is not restricted to white teenage girls. It's across all races and ethnicities. In fact, the desire to lose weight and the attempt to lose weight is actually the highest in Hispanic youth. But that's not anorexia nervosa. This is anorexia nervosa. It's not a new disease. It's not a fad disease. Anyone know when it was first described? Any of the residents? Pardon? I can't hear. Probably was. It probably was. But it was actually in the 1600s by Richard Morton. And actually, it's a disease characterized by voluntary self-starvation. And even in this emaciated state, these individuals consider themselves to be too fat. It occurs primarily in girls, but you do see it in boys. And in fact, one of the 2 initial cases described was a male. So what's happening with the epidemiology? Firstly, we're seeing much larger numbers of males. Not clear if it's because we are better able to identify them or whether they've been hidden all these years, but we certainly are seeing more of them. We're also seeing more in minority populations in the country, and also we're seeing more in countries where they were not previously seen. For example, in Fiji, before the advent of television, no eating disorders were noted. But after the advent of television, the incidence increased greatly. And we are seeing younger and younger ages. The youngest patients I've seen, I think, is a 7-year-old, and I'm sure it's not uncommon to see a 9, 10, or 11-year-old. And you can see over here that from 1999 to 2006, hospitalizations for children under the age of 12 increased dramatically. Well, is this better recognition, or is the incidence, that is the number of new cases per population, increasing? This is a great study from the Mayo Clinic some time ago, but what was good about the study is it looked at the number of cases, new cases, over a defined period of time. And what you can see over here is that in the blue, for adults, the incidence was relatively stable. But it was the adolescents shown here in the red where there was an exponential increase from the 1970s to the 1980s, and that has continued. In fact, a recent study from a community sample in the Netherlands shows that about 5 to 6% of females have a lifetime prevalence of a DSM-5 eating disorder. Obviously, it's lower in males, but 1 in 200 adolescent girls suffer from anorexia nervosa. Peak age of onset is 13 to 15, and for bulimia, it's a little bit later. So is this a mental disorder? You may read that in the literature. I would argue not. I would say it's either a biological disease, and we're learning more and more about it, or at least a biopsychosocial disorder. And the pediatrician has a major role to play. The role is to help in make the diagnosis, because usually the parents will come to the pediatrician, right? And it's also to exclude other causes of weight loss or vomiting, to recognize and treat some of the medical complications, and if not to be the leader of the team, at least an important member of the treatment team. These are the diagnostic criteria for anorexia nervosa, and there is restriction of energy intake relative to requirements, which leads to a low body weight for age, sex, developmental trajectory, and physical health. There are no numbers here. There's no less than 85% of ideal body weight, and that is a change from DSM-4. There is also this intense fear of gaining weight and a distortion in the way they perceive themselves. It's very difficult to deal with in treatment. And there are 2 types, the restricting type and the binge eating purging type. Bulimia the key feature about bulimia is not the throwing up, it's actually the binging. Bulimia comes from the Latin word meaning ox. It's the binging episodes. And a binge has two elements. One is that the amount of food is excessive, and two is that there's a sense of lack of control during that binge. And then there are the inappropriate compensatory behaviors. We all know about self-induced vomiting, but starvation counts. So if you binge the day before and you decide, hey, I'm not going to eat for 2-3 days, or I'm going to go and work out in the gym for 3 hours a day, that too counts. But in addition, there's self-induced vomiting, the use of laxatives or diuretics. And there has to be some chronicity. So these activities have to occur at least once a week for a period of 3 months. But there is a whole spectrum of eating disorders. We said so many of our patients are trying to lose weight, but where on the spectrum does your patient fall? And in fact, a study at Stanford by Rebecca Peebles showed that the vast majority of patients presenting to our center, and I'm sure to your center too, don't meet criteria for anorexia nervosa or bulimia nervosa. But really at the time they met criteria for this weight basket called EDNOS, which is eating disorder not otherwise specified. Fortunately, with DSM-5, we've been able to reduce this group over here. Now, in addition to anorexia nervosa and bulimia nervosa, there is binge eating disorder, which describes people who binge but don't throw up. And that's pretty common. There is also this condition called avoidant restrictive food intake disorder, or ARFID. And this is very common and seen by many pediatricians, developmental pediatricians, regular pediatricians, gastroenterologists, and we'll talk a little bit about that in a second. But there's also this condition called atypical anorexia nervosa, and this describes people who were previously overweight, but are now of normal weight, but have all the cognitions of someone with true anorexia nervosa. And so if you're a pediatrician in the community and you have someone who's 250 pounds and you tell them that they need to lose weight, that's fine, but continue to monitor them, because classically they may lose 100 pounds by resorting to dieting or self-induced vomiting or diet pills, and then they come into your office at a normal weight, but they may be medically unstable. So this is ARFID, and it's a condition characterized by avoidance of certain foods. It could be because of color, consistency, texture, but to the point where it causes failure to grow and develop or weight loss. So they can come with short stature or inability to make expected weight gains. There's also a subgroup of young people who may have had an unpleasant episode, such as choking on a hamburger or a hot dog, and there's fear of vomiting. So there are a couple of subcategories: the picky eaters, the fear of vomiting group, and also some of the kids that have autism spectrum disorder also have some of these features. Some of our colleagues looked at a sample of patients, 215 patients, and when they applied DSM-5 criteria to the same group of patients, DSM-5 in the red, you can see that the EDNOS category was reduced by about 50%, and about 14% of patients referred to a program such as ours and such as yours meet criteria for ARFID. But not everyone who comes to your practice with weight loss has an eating disorder. This is a young girl who'd lost 25% of her body weight. She presented to our program in New York. She was vomiting. She wasn't trying to lose weight, and she had no distortion in body image. Any of the residents want to guess what the diagnosis is based on this X-ray? Well, when you took her history, you found out that she could tolerate liquids but not solids. So she has, someone's mentioned achalasia. You can see the beaking over here of the distal esophagus. She did not have an eating disorder. Here is someone as well who'd lost a lot of weight. but on the CBC, the ESR was slightly elevated. That's extremely unusual with malnutrition. There was no history of abdominal pain, but we consulted with GI, and she had filling defect in the right lower quadrant, and she had ulceration in her terminal ileum. She had Crohn's disease. And here is someone, I was consulted, I remember it was a Friday afternoon, a 20-year-old in the internal medicine ICU. She weighed 55 pounds. They didn't know what to do. She was losing weight there. So I said, well, why don't you put down an NG tube? She had been in the ICU for a week, and we'll come over after clinic and see her. So they put down an NG tube, and I think they had trouble getting that NG tube down because it looks like it's stuck over here. But they did an X-ray. And anyone know what the diagnosis is? Something going on in the right upper lobe. She had tuberculosis. This is New York, maybe 10, 12 years ago. She had visited India the summer before. She developed tuberculosis. We've had patients present to our program with HIV, but rule out anorexia nervosa. And the diagnosis was made by one of our faculty that that person had HIV. And my final case is in the fall. I was called by a pediatrician who said, we've got a patient with anorexia nervosa for you. She was a 12-year-old. She had decreased appetite, weakness. She had lost 5 pounds, and she had been vomiting. It was not self-induced vomiting, though. But when we took a history, she wasn't trying to lose weight, and there was no distortion in body image. You can see her height, and you can see her weight. Her blood pressure was low, very low, and her pulse was high. That's an unusual constellation of physical findings. And if you look at the electrolytes, you can see that her sodium was low and her potassium was high. Anyone know the diagnosis? Back of the room. Pardon? Diabetes? No, that's a good thought, though. Not diabetes. But here's a picture of her, and her family has allowed us to use this picture. This was at the end of the summer, and here's this little girl. She looks pretty miserable, and you can see that she's a lot darker than her family. Addison's disease. That constellation of electrolytes is suggestive of Addison's disease. So, and that was, we wrote up as a case report. So just very quickly to review some of the medical complications, and then we'll talk more about some of the controversies. The medical complications can affect every single organ system. It is important to examine your patient. Don't just pull up the sleeves, because if you do that, you will miss the proximal muscle atrophy, the intercostal wasting, the protuberant abdomen, the dermatitis that you see with malnutrition. Look at the hands. This is Russell sign caused by self-induced vomiting. Carotenemia, this is my hand over here. This is my patient's hand. That yellow discoloration, probably caused by eating a lot of carrots and other pigmented vegetables, as well as some vitamin A abnormalities or abnormalities in metabolism of vitamin A by the liver. Acrocyanosis, often misdiagnosed as Raynaud's, and then the fine lanugo that we see in the nursery. The most common electrolyte abnormality for the boards is hypokalemia, but you can see hyponatremia in young women and young boys who are drinking a lot of water to try and make weight for your physical examination. And this can cause seizures, and we've seen that a couple of times as well. And I'll talk more about the hypophosphatemia and hypomagnesemia in a bit. What often gets them into the hospital are the cardiac abnormalities. Bradycardia can be profound. It can be in their 30s or 40s. Orthostatic hypotension. And then what we're really worried about is the prolonged QTC. But I don't know how many members of the audience remember Karen Carpenter. She was a folk singer, I think, in the 80s, and she died supposedly of a heart attack. She had emetine cardiomyopathy. At the time, Ipecac was widely available for young children who ingested toxic substances, and they were told to take Ipecac, and Ipecac caused you to vomit. People with bulimia can abuse Ipecac. Fortunately, it's not easily available, although you can get it on the internet. And it causes necrosis of striatal muscle as well as cardiac muscle. And then it affects the whole GI tract. It's very common to have parotid hypertrophy in those who binge or purge, loss of dental enamel. Delayed transit time is common. They're always complaining of feeling bloated, full, constipated. Elevated transaminases can occur in about a third of patients. And then not infrequently, you see the SMA syndrome, the superior mesenteric artery syndrome. If you remember the superior mesenteric artery comes off the celiac plexus at an angle, acute angle, and it's kept patent by the fat pad. And if you lose that fat pad for any reason, not only an eating disorder, that angle becomes more acute and you get an external functional obstruction of the celiac, or of the duodenum, causing pain and vomiting after eating. But as an adolescent medicine provider, I'm most concerned about some of the effects that impact puberty and can be irreversible, such as growth retardation. Here is someone who basically had an eating disorder at the age of 9. She regains the weight, has a bit of a relapse over here, but now at the age of 17, she's of normal weight, but look, she's growth stunted. So that is forever. In addition, the impact on puberty, its effect on peak bone mass acquisition, and also some of the brain changes. So because you get suppression of the hypothalamus, you almost get a postmenopausal state. Low LH, low FSH, and low estradiol levels. Why is this important? Because the greater the duration of amenorrhea, the lower bone mineral density. And that relationship is shown over here. The longer the duration of amenorrhea, the lower the bone mineral density. And we know that low bone mineral density is very common in eating disorders, particularly in anorexia nervosa. In this study on your left, you can see in adults, about 90% of patients on presentation have a bone mineral density T-score lower than -1. The T-score is in comparison to the young adult mean. In pediatrics, though, we don't use T-scores, we use Z-scores, which is a comparison to the age match mean. And here on the right, you can see in our group, about 80% of young adolescents had a Z-score lower than -1, and about a third had a Z-score lower than -2, which is defined as low bone mineral density for age. Well, theoretically, if it got better, that would be fine. But here's a patient of mine who was 14. You can see her bone mineral density was in the normal range, but despite treatment over time, she began to lose. She gained weight, actually, but she lost bone mass. And at the age of 19, she went off to college in upstate New York, fell on the ice, and sustained a fracture of a humerus. So it's not just a finding on DEXA, but it's actually a finding that has repercussions. And it's not only restricted to girls. Over here, you can see a study from the group in Boston that at every single site examined, bone mineral density of those with anorexia nervosa, shown here in the dark columns, was significantly lower than age-matched controls. And finally, this is a paper that our group published last year, using a database from the United Kingdom and looking at almost 10,000 adults with anorexia nervosa and almost 100,000 age-matched controls. And you can see here that for females, at every decade of life, the risk of fracture was significantly higher. In males, it was only higher in those over the age of 40 for some reason. Not sure why. And my final picture is a picture of an MRI. This is a paper from '96. This is a coronal section of an 11-year-old on your left. And if you look at the size of the ventricles compared to a normal 11-year-old, this patient has anorexia nervosa, this is a normal control. So you get cortical atrophy that is only partially reversible with weight restoration. So those are some of the medical complications that one should be aware of. Treatment is best conducted by a team of individuals, and the pediatrician is an important part of that team. Our roles are really to stabilize the patient, and that's the stuff that we're really good at, right? It's very easy to correct electrolytes. We can do that within 24 hours. We're good at that. We train to do that. It's not so easy to get someone to gain weight when they don't want to gain weight. And it's actually important to try and manage some of the complications I've talked about. And by the way, we don't really know how to manage all of those yet. So these are the indications for hospitalization. I would guess you use similar indications over here. They're from the Society for Adolescent Health and Medicine. They're not actually, they weren't really derived from data. They were derived from consensus of opinion. So it's clear if someone has electrolyte abnormalities, they need to be hospitalized. Someone who's severely malnourished, less than 75% of expected body weight. We use a heart rate of lower than 50 during the day to admit a patient. And we use hypertension lower than 90/45. And a change in pulse from lying to standing of more than 20 beats, or a drop in systolic blood pressure of more than 20 millimeters of mercury. And these are objective criteria that help us escalate that patient to a higher level of care. And by the way, we've also published papers together with a consortium of other people that show that those who end up in the hospital tend to do better 1 year later. But once you hospitalize patients, it takes a while to get weight gain. This is a study from 1994, a long time ago, when we used behavioral contracts. And you can see that if you increase the expected rate of weight gain, patients do that. But at that time, it took a month to gain 10 pounds. But what happens if you need to gain 20 pounds? So one might say, well, increase the rate of refeeding. So this is a series of case reports. This is a young person who came in. She was 12 years old. She had anorexia nervosa. She weighed 68 pounds, and she was tall. She was about 5'8". So we started to refeed her, and we refed her very slowly, starting at 500 calories a day. On day 3, she had a cardiac arrest. The resident noted that, sent her to the ICU. She got resuscitated there, but they only did a Chem 6. They didn't do other electrolytes. When she came back to our ward, we found out that her phosphorus, which was 4.1, had plummeted to 1.4. So she was given phosphorus. She did okay. And then she required NG feeding on about day 9. And once again, she went into cardiac arrest. This time, they did repeat the phosphorus, and here you can see the phosphorus had dropped again. They put in a cardiac pacemaker, and she did fine, but she did develop delirium at weeks 3 to 4. And this is what we know as the refeeding syndrome. So the refeeding syndrome is potentially fatal. It's not limited to anorexia nervosa or eating disorders. It actually was first described after the Second World War and also noted in people getting TPN, usually adults who were chronically ill or had inflammatory bowel disease. The best studies actually were done in young men, not adolescents with eating disorders, but 36 young men who were conscientious objectors, did not want to fight in the Second World War. And here again, just to involve the residents, how many calories do you think these people were put on over a period of 6 months? Shout it out. Just a number. Correct. But Dr. Silver, you're not supposed to answer. You know, You know the answers. No, but this is important because they were started on 1,600 calories. They were treated semi-starved on 1,600 calories. And this is what happens to young men on 1,600 calories. It's semi-starvation. And it shows how little we know about nutrition. It's not enough for a young person. They need a lot more than that. I'm going to miss this a second, skip this. But what happened is when they were started to be refed, many of them lost weight, 2/3 of them lost weight, and some of them developed the features of the refeeding syndrome. So this is the refeeding syndrome. It's hypotension, cardiac failure, edema, weakness, confusion, delirium, rhabdomyolysis, seizures, coma, and sudden death. It's a rare phenomenon, but it is preventable. The metabolic consequences of that, or precursors of that, are the electrolyte abnormalities shown over here: hypophosphatemia, hypomagnesemia, hypokalemia. And the thought is that during starvation, glycogen stores are depleted, patients convert to lipolysis and gluconeogenesis. When you start to, and they do fine, by the way, for a while. And then when you refeed them, meaning well, but suddenly what happens is you give carbohydrates, there's an insulin surge, electrolytes are transferred intracellularly, so you get extracellular hypophosphatemia, hypokalemia, and hypomagnesemia. And that actually can cause the tachyarrhythmias and the sudden cardiac death that has been well described. What do we know about hypophosphatemia? Well, we know it's most likely to occur in those who are severely malnourished, and we also know it's most likely to occur during the first week of refeeding. We know that the phosphorus nadir is directly related to the degree of malnutrition. So the lower the degree, the more malnourished, the lower the phosphorus level. But it can occur even in those who are not malnourished after periods of starvation for days to weeks, so in a healthy, normal weight person. As a result of this, there are very clear guidelines as to very conservative management to prevent the refeeding syndrome. And they're shown over here from the American Dietetic Association, now called AND, right, for dietitians in the audience, the National Institutes for Health, and the American Psychiatric Association. If you look at the NICE guidelines, they actually recommend 10 kilocalories per day per kilogram. So that's 500 calories a day for, say, a 110-pound girl. Just think about that. That's what's recommended currently. Well, you may recognize Dr. Silber over here. And in a way, he was a visionary because a long time ago, in 2002, he and the team over here published 2 papers looking at starting patients on much higher numbers of calories and being able to do that safely. So this was not a randomized controlled trial, but the way I understand it, and maybe he can explain better afterwards, it was a comparison of a change in management plan from 1995 in comparison with about 50 patients after that to about 50 patients before that. And what he found is that by giving nasogastric feeding overnight, weight gain was significantly higher, change in BMI was significantly better, but there was no change in length of stay in this patient population. And at that time, patients were in the hospital for about 3 weeks, which is still a fairly long period of time. It took 10 years later until others started to find the same thing. And this over here is a study by Andrea Garber at UCSF. And what she found in 35 patients is that the majority of patients lost weight during refeeding. And it wasn't really until day 8 when they began to gain weight. And that higher calories prescribed at baseline were associated with greater weight gain and shorter hospital stay. Again, something that Dr. Silber had started 10 years before. But at that time, it was even more controversial than it is now. And then at about the same time we published this study, this was a retrospective study looking at about 300 patients, about 91 of whom were treated with lower calories, and that's about 1,200 calories a day, compared to those who started on higher calories, that's about somewhere between 1,400 to 2,000 calories a day. And what we found is that, not advanced. We found that length of stay was reduced, and there was no increased incidence in the electrolyte abnormalities associated with refeeding. If anything, you can see here the incidence of hypophosphatemia, hypomagnesemia, and hypokalemia in the higher calories, shown here in the red, was probably a little bit lower, but not significantly so. So we concluded that length of stay was significantly shorter in the higher calorie group, and there were no differences in the rates of these electrolyte abnormalities. What we did find is that hypophosphatemia is really associated with the degree of malnutrition, but not the rates of refeeding or the amount of calories. And this is very, very, very important. And none of our subjects developed the refeeding syndrome, similar to Dr. Silver's work. Well, just to get you up to speed very quickly where we are now. So here, this is what's out there in the literature. Here is a study from Australia, also very similar. When patients are admitted, they're given an NG tube, 2,000 calories straight away, and showing their outcome, and they use phosphorus supplementation for all of their patients. I know you do that over here, but it's not generally recommended. Most programs start off with regular foods, meaning 3 meals and 2 snacks, but not NG feeding. But here in Australia, that is the standard of care, as it is at your unit. The only published, this is not advancing. Okay, here we go. The only published randomized controlled trial was published 2 years ago from the United Kingdom. And look at the data over here. 36 subjects from 6 different units in the United Kingdom comparing higher calorie refeeding, so that's 1,200 calories, that's our lower calorie, right, to lower calorie, which is 500 calories. So this is what's out there in the literature. And what they found is that those randomized to higher calories had greater weight gain after 10 days, and their major outcome was the QTC. The point being is this is what's out there. And I know you're doing what you're doing and we're doing what we're doing, but no one knows what's the best and what's the safest. So we actually are now in year 3 of a randomized controlled trial with 3 aims. The first one is to compare the efficacy of lower calorie refeeding versus high calorie refeeding over 12 months follow-up, and I will explain what that is. And we hypothesize that high calorie will actually be better in terms of achievement of clinical remission at a year, and that's defined as achievement of a weight greater than 95% of median BMI, plus an eating disorder, an EEQ, that's an assessment of eating disorder symptoms within 1 standard deviation of clinical norms. We also hypothesize that it will be as safe, as evidenced by no increased incidence of electrolyte abnormalities. And I think the most interesting of all is we're studying cost effectiveness. That is, the cost, including not only the cost of that hospitalization, but the cost of subsequent hospitalizations and hospitalizations elsewhere in partial programs, and also including days missed from school and days missed from work for the parents. And we include those with anorexia nervosa or atypical anorexia nervosa. Our intent is to enroll 120 patients. We are actually up to 93 patients have been enrolled. We use the SAM criteria. We exclude those with bulimia nervosa. And within 24 hours of enrollment, our research coordinator approaches the patients to see whether they're interested in being randomized to either higher calorie or lower calorie. Our lower calorie starts at 1,400 and goes up by 200 calories every other day. so probably a lot lower than what you're doing here. And then our high calorie starts at 2,000 and goes up by every day. And they ultimately reach their goal based on the dietitian assessment of what they need, but they do that at different times, obviously. Here is just to show that we've enrolled, at that time there were 80, that was the end of December, there are now 93 subjects. And a fair number, probably about, by now I think 20 in each group have been followed for 1 year. We obviously don't have the results yet. This is an RCT, we're blinded to the results. But I hope that this will be able to inform clinical practice. Here, we don't prophylactically treat with phosphorus, but we have a protocol that's in our EPIC. So there's an order set. If the level is such and such, we give that amount of NutriPhos supplementation, and the same for MAG and the same for hypokalemia. And just to say, it's not just one person, it's a whole team of individuals. And so it's a whole village. And this is a collaborative study between us and UCSF, 2 clinical sites, and a 3rd site where the data management is performed. So we've talked a little bit about refeeding, and just to end off, just a little bit about bed rest. Like I said, many units were keeping patients on bed rest for many days, and the intent is to try and let the families know that this is a serious illness, we want to conserve energy, etc. But maybe that's not such a good thing. So this is a study that was published a couple of years back, and the intent actually was to look at the impact of a jumping activity on bone health, but also look at stabilization of vital signs. So it was a randomized controlled trial with 41 adolescents. You can see their age over here. They were randomly assigned to a jumping activity or routine care, and those who were assigned to the jumping, everything else was the same. And we measured bone markers at 3 time points: baseline, days 4 to 6, and days 7 to 9. And we're really interested in the bone markers, bone-specific alkaline phosphatase at different time points. And here you can see the patients were similar at baseline, no significant differences. And after 24 hours of monitoring on bed rest, those assigned to the jumping activities did the jumps under supervision, holding onto a ballet bar. And this was completed within 5 minutes. It was done twice a day, and it was supervised by one of our study staff. And what we found is that there really were no significant differences in the bone markers. And I'll just pass through this. But we did find that those who were jumping more frequently actually stabilized their vital signs much quicker than those who were kept on the standard bed rest. And actually, look at the length of stay. 11.6 days versus 17 days. So it makes us think and challenge what we're doing, and perhaps we should get our patients ambulatory much quicker. Most importantly, this did not affect weight gain at all. So I'm going to leave some room and time for questions, and I just want to read the poem. But my take-home points are: be aware of the possibility of an eating disorder, even in boys and even in younger children. Inpatient refeeding protocols can really be much more aggressive than previously described. There are different ways of doing it. We don't know which is best. But the concern of the refeeding syndrome is really, it's real, but fortunately it's rare. But it's more likely to occur in those who are severely malnourished, and it doesn't depend as much on what you're giving them to eat or how fast. And finally, don't keep patients on bed rest for too long. And if I may, I'd like to read a poem written by one of our patients, a 17-year-old, and then I'll open it up to questions. So it's entitled Thoughts of an Anorexic. What life is like for people like me, trying to go on, trying to see, a situation and answer just maybe a clue to continue life living the way that we do. Twisting and turning is that hunger I feel. Hold out a little longer, that too will be sealed. Why? Just wait, because we have learned to overcome that sensation, to have no more yearns. Sometimes we give in because people urge, but then guilt takes over, making us purge. For we must be empty, we must be clean, to be the best, to be slim and lean. We lie at night in our beds full of fright, that one day will come a day we can't fight. But now we are fine as can be, as we run our hands down to feel and to see. The peaks, the depths felt all around. Another bone appears as the weight goes down. Then lightning strikes, the day has come. We can no longer fight and we can no longer run. The family cries out and the doctor agrees, this can't go on, a hospital she needs. So there we are placed to eat and to learn, whether we want to or not, and they can be firm. Then comes the day, the time to depart. We are through here, we now know our part, but are we all better, as good as can be? We know we're not, but no one else seems to see. The pill has been swallowed, but it doesn't affect that driving need we so strongly select. What could that be that has such hold? Well, my friends, that's the need for control. For when our lives are out of hand, we seek to conform to the loves of this land. Discipline, thinness, beauty is the way to make you complete, the star of the day. Control our food is the answer we find, but soon that takes over as we become more entwined. But starve ourselves not, living always with fear, or going back to that peace of being taken from here. So live on, laugh on, but utter not a word. They don't understand and they think we're absurd. Sometimes we say, give it up, and we try, but happiness fails us, ending only to cry. When will it end? We heave with a sigh. We know not the answer and wish only to die, unless perhaps you have some clue to continue life living the way that we do. Thank you. I'll be happy to take any questions. Yes.
Thank you for this most important lecture. Really appreciate it. My question is, of course, you focused on medical and pediatric issues, which obviously is our audience. Can you speak a little bit about the psychiatric, educational aspect of it, and whether this can be considered a form of addiction in terms of how one would work on, and the connection between those approaches and the medical approaches?
Yeah, no, thank you for that question. The question was the psychiatric piece. I'm actually speaking to psychiatry, I believe, at 11 o'clock, so I'm going to try and deal more with that. We don't believe that this is similar to the addiction model. No, we certainly, our field is biopsychosocial, we think, and I think that our psychiatry colleagues, some of whom may be in the room, also agree that nutrition is an important piece of the treatment. Many of our patients have comorbid anxiety disorders, OCD, and depression, but those two are aggravated by nutrition. So the first piece is really nutritional rehabilitation by whatever method. The current state of art is really family-based treatment, which is very different from what used to be done 20, 30 years ago. And in FBT, the families are empowered to treat and refeed their children. It's not an addiction model. I know we hear out there that people are addicted to food. It's really, it's a biopsychosocial model where there are predisposing factors, precipitating factors, and perpetuating factors. And I will talk about that at 11. But actually, there also are some genetic factors. So there are wonderful GWAS studies that have shown on chromosome 12, there are some foci or loci. So one can be predisposed to this disease, but it's actually dieting that perpetuates what's going on. And I showed you those pictures of those young men, right, who are voluntarily starved. Many of those young men developed the bradycardia, the hypotension, the orthostasis, the low bone mineral density, but also the preoccupations with shape and weight. They began to dream of foods, they hid recipes. One became depressed and tried to commit suicide, and a couple became bulimic as well. So I don't know if I've really answered your question, but it's not an addiction model. It's really thought to be secondary to malnutrition, but also with biological predispositions that are genetic. And there's also a higher incidence in monozygotic twins compared to dizygotic twins. And any other questions? Yes. So the question was, what goes into the decision not to? So it's really two different philosophies, right? One, I think everyone understands that we need to refeed these patients. Some people will treat the electrolyte abnormality when it's present. Some people treat when phosphorus is going downtrending, which is very confusing, by the way, because different people are doing different things. And some people treat prophylactically. There is no consensus. You've never had the refeeding syndrome, right, Dr. Silber? You have?
Yeah, sure. Yeah, I remember very vividly one patient where I forgot to write the order for supplement phosphorus, and darn it, he developed hemolytic anemia.
Yeah.
So that's basically what I remember.
And by the way, we don't know that it's phosphorus only, by the way. We really don't. These are just assumptions because there are some articles from the 80s, and that's not that long ago, showing one of those articles in the internal medicine literature was 3 patients who died in the hospital. And one had anorexia nervosa, one had cancer, I believe, and one was on TPN for inflammatory bowel disease. And they showed the EKG tracings of their tachyarrhythmias, and I think 1 or 2 of those had a low phosphorus. Nowhere in the article did they mention that. So it could be other electrolyte abnormalities as well. You know, do you routinely supplement potassium or magnesium? No, so we don't know. And then also thiamine deficiency can also do this. So it's a syndrome with multiple causes. And so I just say that it's different approaches, and we don't know what's better. I think that different places do different things, but I think we all understand that it is potentially dangerous and that we can treat these young people well, provided we monitor them carefully. I think that's the most important. Yes?
I'm curious as to how you came up with jumping as your exercise to look at with your population.
Yeah, so again, the question was how we came up with jumping. We don't really know how to treat low bone mineral density in anorexia nervosa. We really don't. But we do know that the major determinant of bone mass is actually body weight, because the more you impact, the greater the impact, the force on your bones, the greater the stimulus for bone formation. So jumping activity does that. For example, gymnasts have higher bone mass than non-gymnasts, provided they have regular periods, right? And so basketball players have high bone mass. So it's weight-bearing activities, jumping activities, whereas swimmers or cyclists don't have great bone mass. So, but we didn't know how much jumping activity would be safe. And so the intent is ideally one should repeat the study, but have a much more intense intervention, I think.
And other forms of exercise, think about any different recommendations that you might have. And for example, on an ongoing basis for treatment for these kiddos, a lot of them exercise is part of their pathology.
Right, so exercise, that is a big issue, how much exercise. We restrict exercise until they gain weight, begin to gain weight. But for their bones, actually, weight-bearing exercise is helpful. So here again, walking, I would recommend walking and then jumping activities with time, over time, but in preference to swimming or cycling, as an example. But also, lifting weights is helpful. And so the impact is local. Rowers have better bone mass of their spine. If you're lifting weights, it will probably be your arms. If you're a tennis player, it will be your dominant hand. Okay. Dr. Silva.
Neville, I've followed your career for many, many years. I'm always happy when I read one of your papers because you put so much discipline, order in something that has been more an artistic field. And I was also impressed by the poem that you read. It's very sad. And it gives me the feeling, you know, so many people talk about control. That's an issue of control. And it's actually, in my mind, an issue of lack of control.
Right.
That the anorexic ideations have taken over the entire life, and they've lost control over that. So thank you very much. And I want to invite whoever can join us. Dr. Golden is going to have a conversation with us, a breakfast meeting in the conference room that's next to GME. And then at 11, he's going to do a presentation for psychiatric runarounds. Thank you again.